welcome to our Modifier Monday. We're going to be talking about Modifier 25 today. My name is Rachel Wood, and I'm one of the nurse analysts with the Provider Outreach and Education team. I'm joined today by a couple of my coworkers. I'm joined by the fellow nurses in Provider Outreach. Mary Sue and Jennifer are on with us, as well as Ellen, and she's going to be monitoring our chat as we go through these slides today. So if you do have any problems or any issues as I'm talking through this information, you can email us at wps.gha.education@wpsic.com. And those would be for technical difficulties. Any questions that you might have, you can put those into our chat, and we are going to be answering them. Either if we don't get to your question today, we may have time at the end, but we do have a good amount of content and pre-submitted questions to get through. So if we do not get to your question today, we will send out a document with all of the outstanding questions to participants following our webinar. So just keep that in mind if you put a question in and you don't get a response. All right, so here's our disclaimer. Really quick to go through this. Basically, Medicare's rules change from time to time. I am presenting and talking about the rules and regulations as they stand today. However, if anything does change once we conclude our webinar, please follow any updated Medicare communications, and that would take precedence over the content presented this morning. Additionally, we are recording this, so please no recording this yourself. We will be posting this, depending on how the recording does come out, to our YouTube channel following today's presentation. If you want to take a look at anything that I've gone through, or maybe somebody you work with was not able to make it today, we will be, again, posting that recording. All right, so here's our agenda and objectives plan for this morning. So we'll be talking about the use of Modifier 25 and what this modifier is used for, common correct uses, some common errors, and when we see people, so when not to use this modifier, and then we will talk through some examples as well as we get to some of our pre-submitted questions. The answers to those, we do have some questions I'll read through. Additionally, as I go through some of these slides, we mixed in some of the content that was asked prior to today into the presentation. So that's our plan. And before we get into that, we have not done a Modifier Monday in a little bit. So before we got into Modifier 25, I just briefly wanted to mention, what modifiers are in general. So when we say modifier, what comes to mind? Hopefully, it's a 2-digit code added to a procedure code to help clarify the procedure code submitted for billing. Modifiers help us understand what is in the documentation. So we'll review more documentation, examples and what we'd be looking for specifically for Modifier 25 later in our webinar. Medicare uses 2 different modifier types. They are payment and informational. So a payment modifier directly affects reimbursement. So some examples of these might be, modifiers TC or, the modifiers that signify right or left. The other category is informational modifiers. These do not affect the amount allowed. They instead provide coverage information. So some examples of that would be modifier QJ, which would be Medicare beneficiaries in the state or local custody, or beneficiary notice initiative modifiers that we, again, I'm not going to be talking about any of these specifically, just kind of wanted to mention the different types. And then, one common question we receive, do modifiers change the written definition of a procedure code? And the answer to that would be no, that's not the job of a modifier. The job is to add information and to give a little bit more, feedback for the billing and reviewers. All right, so that's just a brief review of what modifiers are in general. I want to now talk about Modifier 25. So that's our main modifier for this Monday. So this modifier is used to report an evaluation and management or E&M service on a day when another service was provided to the patient by the same physician or other qualified healthcare professional. So the American Medical Association, or AMA, CPT book defines Modifier 25 as a significant, separately identifiable E&M service, again, by that same physician or other qualified health professional on the same day of the procedure or other service. It may be necessary to indicate on that day a procedure or service identified by a CPT code was performed. The patient's condition required a significant separate E&M service that was above and beyond the other service provided or beyond the usual pre-op or post-operative care that is associated with the procedure that was performed. So a significant separately identifiable E&M service is defined by documentation that shows the relevant criteria for that respective E&M that is reported, and then what else are you doing that's separate from that. So the E&M service may be prompted by the symptom or condition that the procedure or service was provided for. Different diagnoses are not required for reporting the E&M services on the same day. This circumstance may be reported by adding Modifier 25 to that appropriate level of E&M service. So Medicare requires that Modifier 25 be only used on claims for E&M services and only when these services are provided by the same practitioner, so physician or other qualified non-physician practitioner, to the same patient on the same day of another procedure or service. So I am going to probably repeat that as I go through our slides and examples a couple times, but that is the main goal of Modifier 25 and the main thing that it's signifying to and why it's used. All right, so let's look at the correct usage of Modifier 25 when deciding whether to use this or not. So when deciding whether Modifier 25 is appropriate for your claim or not, ask yourself some of the following questions. And these questions are based on why is the patient being seen. So are there signs, symptoms, or conditions that the physician or other qualified healthcare professional must address before deciding to perform a procedure or service? So, use this modifier to indicate that an E&M service was provided, again, on that same day as another procedure that would normally bundle under the National Correct Coding Initiative, or NCCI. So in this situation, modifier signifies that the E&M service was performed for a reason unrelated to the other procedures performed that day. Another question to ask would be, were the physician or other qualified healthcare professionals' evaluation and management of the problem significant and beyond the normal preoperative and postoperative work? So to expand a little bit here, since we did receive this as a pre-submitted question, all procedures will have the pre and post-op care built into the payment of the procedure code. So the basic and standard pre-op eval would not qualify as, beyond the normal. So Modifier 25 is used to indicate that an E&M service was performed on the same day as a minor surgery, so 0 to 10 global days, and performed by the surgeon, and it is significant and separately identifiable from the usual work for that surgery. So again, this is going to vary based on the surgery in question, but things like standard history that relate to that procedure, vital signs, and so on, those would be considered something that would be normal and standard in pre-op or post-op care. Was the procedure or service scheduled before the patient encounter? Is there one or more diagnoses present that is being addressed or affecting the treatment and outcome? So a different ICD-10 code from one submitted for minor surgery, that is not required with the E&M code. Diagnoses for E&M service and other procedures may be the same or different. So Medicare does not require a different diagnosis for the E&M from the procedure diagnosis to use Modifier 25. To bill for an E&M service, the provider must document a history, an exam, their medical decision-making in that process. All procedures include some service related to the patient evaluation and management. So the physician must determine whether the problem is significant enough to require additional work to perform key components of the problem-oriented E&M service. And I am going to have, towards the end of our slides, 2 examples that we'll walk through that go through some correct usage of Modifier 25. Keep in mind, there can be a wide variety of different scenarios, but we have just 2 examples that we'll go through this morning. All right, so what would be considered incorrect use for this modifier? So on our slide here, we listed some reasons that would be considered incorrect usage for Modifier 25. All right, so do not bill this if it is billed with a procedure or service with no global fee period. Do not use Modifier 25 based on the diagnosis code alone. Do not use this modifier for every evaluation and management service that you bill. So this will be a red flag to WPS if that is what your facility or, for physicians do. So make sure that this is, something that you're not getting into a habit of adding to all claims no matter what. Additionally, Modifier 25 does not need to be added to Medicare claims or services that are automatically excluded from the Medicare programs. So that means services that are not covered by Medicare, so that Medicare never covers. You do not need to add modifier and should not add Modifier 25 to those services. Do not use Modifier 25 by a physician or other physician that is different from the one that did that initial evaluation and management performing the procedure. So again, this needs to be done, the service or procedure needs to be done by the same physician or health professional on the same day of the procedure, of the other procedure or other service. Do not use this when documentation shows the amount of work performed is consistent with the normally performed amount of work for that procedure. We talked a little bit about that already. Do not use this modifier when documentation doesn't support, again, a significant or separately identifiable E&M service. So the person came in for one thing, that is the one thing that you provided. Modifier 25 would not be appropriate in this situation. Do not bill with CPT code 99211. So this code 99211 is used to bill for a low-level evaluation and management visit. That does not require a provider to be present with the patient or to have key components documented, so history, examination, and medical decision-making. That is per the CPT guidelines. So the use of Modifier 25 requires that these components do need to be documented with the E&M service. So therefore, this code 99211 cannot be appended with the Modifier 25. Do not append to E&M codes that are explicitly for new patient only. So these codes are listed as new patient codes and are automatically excluded from the global surgery package edit. They are reimbursed separately from the surgical procedures, and no modifier is required if the visit meets significant and separately identifiable guidelines. And then again, last on our slide here, I did already mention this, but automatically excluded services from the Medicare program, you do not need to add Modifier 25. All right. So I want to talk a little bit about documentation. So in all cases where Modifier 25 is appropriately applied, the provider must ensure that the documentation present and is included and includes the patient's medical record that shows information to fully support both the visit and the procedure. Documentation for the evaluation and management service must include the key elements, so medically appropriate history and/or examination, the medical decision-making level or the total time that the data service and the data being counter that are required to select that evaluation and management code. We do have a lot more education on evaluation, like how to wrap your head around medical decision-making and total time for the various facilities out on our YouTube page. Ellen has done a lot of great education on that in the last couple months. So if you want some more information on those, please take a look at the encore presentations that we have posted. We would expect that providers will use Modifier 25 only when this can be clearly shown that the visit was medically necessary, significant, and distinctly separate from the procedure or therapeutic service that they provided, again, for that same patient on the same data service. So significant is key here. The documentation should support that the provider performed a great amount of additional work over and above what is normally included in that payment in question. So you should always, as a provider, make sure that, make the goal to make your documentation clear, concise, and legible. So when you're, furnishing the documentation to support the services, it does always help to make sure, again, it's legible, and that is going to support the review if you find yourself in an audit or, targeted probe and educate type of situation. So just things to keep in mind. As a provider, it is important that, you do have a little bit of knowledge on those billing practices that relate to your specialty area. I'm kind of just speaking a little bit as a nurse here, but, if it's not documented, it didn't happen is kind of the thing you need to remember, that as on the reviewer end, if we don't see it in the documentation, we're not going to know your thought process, your thinking, and what kind of went into X, Y, and Z, and will be hard to support the billing. And in this situation, adding on that Modifier 25 if there is a gap in the documentation. So some areas that providers can use for reference. We find that the LCDs or local coverage determinations are really good references for the coverage criteria that we'd be looking for the services that you're, documenting for, reimbursing, looking for reimbursement for, and so on. So just a little side note there with the documentation piece. All right, so some considerations for documentation. When billing an evaluation and management service along with a procedure, your documentation, again, must clearly show and demonstrate that the purpose of the evaluation and management service was to evaluate a specific complaint. The complaint or problem addressed can stand alone as a billable service. You performed extra work that went above and beyond the typical work associated with the procedure code. The key components of the appropriately selected evaluation and management service were actually performed and addressed the presenting complaint. The purpose of the visit was other than evaluating or obtaining information needed to perform that procedure or service. And then finally, both the medically necessary E&M service and the procedure were appropriate and significantly documented by the physician in that medical record to support reimbursement and claims for these services. So we included some suggestions to consider if you practicing at your facility to ensure that the use of Modifier 25 is accurate. So first, perform a self-audit. Ask yourself if you're a provider, does your own billing and coding with this, did I provide the service that was separate and significant than what was the initial E&M selected? Is this information clearly documented in my notes? So self-audits performed periodically can help identify, any incorrect usage, any gaps maybe in knowledge at your facility, and help to identify those before, they kind of sneak in and too much has been submitted. And then before a formal review or audit happens, you can correct those, mistakes or small errors. All right, so I mentioned global surgery in some of the prior slides, and I want to expand a little bit here about this. So Modifier 25 applies to the significant and separately identifiable E&M services. Again, that is above and beyond the usual pre-op or post-operative care and the medical decision-making associated with the procedure. The specific components of the pre-op and post-op work for procedures are included in the data elements that are used by the Relative Value Updated Committee and the information that Medicare assigns for relative value units for minor procedures. So if the services are provided in the evaluation and management visit are more than this typical pre- and post-op service work, they can be considered significant and separately reportable. Global surgery is defined as all necessary services normally furnished by a surgeon before, during, and after a procedure. Medicare payment for a surgical procedure, again, includes all of that care, so pre-op, intraoperative, and post-operative services that are routinely performed by a surgeon or a member of that same group with the same specialty. That's something that, we do want to point out because sometimes people, want or hope that each can be paid separately, and they actually are under this package. So do not use Modifier 25 when billing for services performed during a post-op period if it is related to that previous surgery. Related follow-up exams by the same provider during the global period of a previous procedure are included in that procedure's global surgical package. For an unrelated evaluation and management service during the global period of a previous procedure, you may be able to report that appropriate E&M, but with a different modifier depending on the situation. Modifier 24 may apply. That is for unrelated evaluation and management service by the same physician during a post-op period. So again, and then also some situations may apply with different modifiers than 25, and we do have a good resource on our website that goes through, some more details on different modifiers, but, not to throw too many out there for you, just kind of keep that in mind. And so that's for minor procedures. For major procedures, those would be defined as one procedure that is within a 90-day global period. All right, so that brings us to example 1 on our slide here. And I'm going to talk about 2 examples in our next 2 slides. And just want to, kind of point out with these example situations and, with the nature of E&M and medicine visits, there are a ton of different situations or scenarios that we could talk about and go through. It does make it kind of fun, but it also just, keep in mind we picked just 2 that we think are, kind of common to talk about today. But, with these and all these different scenarios, the basic principles of using Modifier 25, so again, significant and separate, performed by that same physician on the same day for that same patient, apply. All right, so example 1. So we have an established patient that presents to the physician's office for hypertension management. During their appointment, the patient reports having ear itching, so they have some redness, some drainage, and muffled hearing. And the provider does an ear exam, which shows that the patient needs ear irrigation, so they need to have their ear flushed. The provider performs a cardiovascular assessment, and then they do follow that with the ear irrigation to help with that, whatever's going on with that person's ear. So for this example, the appropriate report would be to report the appropriate E&M code, and then appending modifier 25 would apply here to show the significant and separate service that was provided during this patient visit. So the initial purpose of the visit was to evaluate that patient's cardiac status, but during the patient discussion and the exam, the need for an ear eval and procedure to address those symptoms related to the ear went beyond that initial plan for the cardiac evaluation and resulted in a completely separate procedure. All right, so moving to example 2. So in example 2, we have an established patient that presents to a provider's office for evaluation of a growing lesion on their nose. The provider biopsies that lesion and is, looking for possible skin cancer. During that same visit, the patient also reports that they're experiencing some enlarging lesions that are on their scalp that are more dense and scaly in their presentation. So after assessing those separate lesions, the provider determines that the scalp lesions are a certain type of skin issue, diffuse scalp keratosis, and prescribes a topical 5-fluorouracil, and excuse me if I mispronounce that drug, cream, which is a higher level medication to apply to those lesions. They also, with this, discuss the treatment plan with the patient. So for this situation, the appropriate thing to report would be reporting for the biopsy of the skin. So this was the initial reason that the person came in, to have that growing lesion on their nose examined, which then resulted in the provider taking a skin biopsy. The appropriate office visit for the outpatient E&M for that established person, and then appending modifier 25 to that E&M code. So the evaluation or exam of those separate lesions on the scalp, they did not require a biopsy, but they are separate from that initial reason for the visit, and the exam they're separate from the initial reason for the visit, which was the exam of that nose lesion. The provider additionally had to do some medication evaluation and to treat that scalp issue, and did prescribe a higher level of medicine. So that topical 5-FU cream has some prescription drug management there, and education with the patient on how to use that drug and so on. All right. So some final considerations before we get into our resources and our pre-submitted questions. So some final things to kind of talk about with modifier 25 are on our slide here. First, only again, append to E&M services. Be aware of the usual pre-op and post-op care that goes into certain procedures. Make sure to document significant and separately identifiable E&M services in the medical record. And finally, modifier 25 is not restricted to specific levels of evaluation and management services. All right. And then I did mention that we do have a page, and I believe Ellen may have put a link to this into our chat, but we do have a link in our slides as well to our resource page for modifiers. This has some information about modifier 25. It also has a lot of information on other modifiers as well, but if you go to our website, we do have a little bit of a decently, it's not new, super new anymore, but different layout. So this would be under our guides and resources section, and you can find that by going to our homepage, selecting your jurisdiction, and then if you navigate to claims and scroll down a bit on that claims page, you will find the link to the modifier page. But again, we do have a link directly to that in the slides that we provided. All right, so talked us through a lot this afternoon. To summarize, we talked about the modifiers definitions, so what those are, what the purpose is, appropriate and inappropriate use of modifier 25, what to document, and some questions to ask yourself as a provider when you're documenting or reviewing the documentation that has used modifier 25, and then 2 examples of appropriate usage of this modifier. So again, a lot of information to digest, and I want to thank you for staying with me so far. All right, so before we pause and look at our chat questions, I do want to go through some of the outstanding pre-submitted questions that we received. So if we don't get to your question today, again, we will send out a question and answer document via email to participants that, review the questions and outstanding responses after we conclude our webinar today. So just remember that because we do have a good amount of pre-submitted ones I want to talk through. All right, so our first question that we were asked a few times about is modifier 25 updates for 2024. So at this time, we are not aware of any changes to modifier 25 from Medicare. So as of this time, the Medicare guidelines remain the same. The AMA does have some articles out there just talking about using modifier 25. Their guidance and Medicare's guidance can sometimes differ with coding, but again, we do not have any information at this time about updates for Medicare's usage of modifier 25 for 2024. All right, so next question, are there consequences if modifier 25 is accidentally appended to a code that does not require this to be used? So that is a great question. I would say yes, you may run some probability of having issues with your claim. If this is done frequently and often, it could result in your claim being denied. And then you will have to go through that appeals process, et cetera, if that is something that occurs. So we would recommend, saving some time up front and not going down that appeals kind of rabbit hole by just being careful of how liberally modifier 25 is used and to help ward off some of those accidental usage situations. All right. So our next question, can you use modifier 25 on an E&M code when doing an injection on the same visit? So this, an E&M service may be appropriate if the decision to start the series of injection is made after the evaluation during that same visit. So indicate this by using that E&M code, again, with, the modifier 25. This genuinely could apply, would also have to base on the documentation that is completed. And again, make sure that they're separate from why the patient was brought in to the visit initially. All right. All right, so is it appropriate to apply modifier 25 to evaluation and management when an injection, of drug or substance under the skin or muscle is also performed by the nurse on the same day? So this is a good question. All of these are really good questions. So if the procedure is scheduled in advance of the encounter, the medical necessity for that procedure has already been determined and treated, and the treatment, plan has already been decided. So in this case, the purpose of the previous evaluation and management service has been determined, and you cannot charge again for that evaluation and management service for an identical problem on the day of a pre-planned injection. So additionally, to bill a E&M service with a minor office procedure, so as an injection, you must have documentation that supports that the need for that additional assessment is beyond that for the injection. And that's not going to be something that a nurse is going to be able to perform or determine. It does need to be something the separately identifiable procedure and determination with that is something that the provider is determining. The nurse is only following the physician order. So hopefully that makes sense. But yeah, the nurse cannot be the one that is dictating the separate procedures that are being done. All right. How do we know when to use an E&M? For example, a patient is seen for knee pain and ends up getting an injection during that same visit. The provider states that the exam and thought process is more than the normal pre-work that would be included during the procedure code. So this will depend on the documentation that the provider completes. And this documentation is going to be what drives the appropriate codes that are billed. So in the example that is provided, the patient came to the office with a complaint of right knee pain. The physician takes a history, does an exam, and documents all of this in their medical records. So in our pretend example here, they determine that an x-ray of the knee is necessary, and the patient then gets this. The physician writes an order for physical therapy and then determines that the patient would benefit from a follow-up cortisone injection to that affected knee. And this injection is provided, this cortisone injection is provided during that visit. So in this case, a separate and significant E&M service was prompted by the knee pain, and that is, that injection, that cortisone injection was then provided. Now, say the patient is coming back for a repeat cortisone injection, then the questions about the status of the knee pain from that last injection would not support the Modifier 25 because it's something we already, know is going on with them, and we're not doing the initial work to figure out, kind of how the provider did with that initial visit. So again, it will depend on the documentation and the medical record, just to kind of sum up that response. All right, and then our final pre-submitted question is another example question, and the example provided, a patient is inpatient for acute iron deficiency anemia with evidence of black stool that is concerning for an acute GI bleed. The GI physician decides that an urgent evaluation is needed, and they will do a push enteroscope scope that day, and enteroscopy that day, and and so the question here is, should the Modifier 25 be used in this situation? So this procedure typically is something that the patient doesn't typically, I know that not a GI doctor, but typically patient wouldn't eat or drink anything for at least about 8 hours prior to receiving this to get those best results. So, if the doctor knew in advance that the procedure would be happening and does some of that pre-op assessment, and the documentation shows that, then we would consider that to be part of the procedure. Now, so it wouldn't be just they see them and then they immediately do it. There would be a little bit more of a gap in some of the pre-planned aspect to it. If the patient sees the doctor and that doctor believes the procedure needs to be done immediately without that prep time, then the Modifier 25 might be appropriate. So it's really going to just depend on all of the things in the documentation and how fast that procedure was actually provided and what happened beforehand. All right, so we are actually close to the end of time. I am at our resources, and then may have time for just one question. I know I do see that we have some in our chat, so again, we will, if we didn't get to your question today, we'll respond with a follow-up document. On our slide here, we have some links to, again, our WPS modifier page, our CMS links that relate, sections that relate to this modifier, as well as Medicare's Learning Network article on Modifier 25 usage. So really good resources to check out. Then we encourage you to do so if you want to just, get a better, some more background. All right, so I believe we have time for just one question. So Ellen, any questions that we should address to the group now, or, we could also address them via email following today's presentation.
Well, Rachel, I'll go ahead and ask this question. When evaluating the use of Modifier 25, would you consider the same provider to be only that same physician, Dr. Smith, or are you considering Dr. Smith and anyone within that group within the same specialty?
So I believe, and please correct me, Ellen, if I'm misspeaking, it's the second one. So the same group, they would be considered as one physician. And I just want to double check, is that, we're giving correct information on that?
Yes.
Yeah, okay. Yep, so it would be, the second part to that question, the Medicare would consider everybody in the same group to be one physician on that same day. All right, and that is, we are at time here, so I want to thank you all for attending and sticking with us. And I will close out the webinar. So on behalf of WPS and the rest of Provider Outreach, thank you for attending and have an awesome rest of your day. You may now disconnect.